and training. Let me just give you a few words about him. Stefan Mönk is the Chief Medical Officer at the KAI Healthcare. He has worked clinically as senior consultant in anesthesia, as emergency physician at the Mainz University, as a member of a German air rescue service, a chief emergency physician for mass casualty incidents, as an educator in each role. He has co-founded and managed the Mainz University Simulation Center and the for-profit Akai Simulation Center and the Lufthansa Healthcare Training Service. Previous positions held at KEL include leader of the International Healthcare Academy team. His society work spans the European Society of Intensive Care Medicine, PAC Simulation Program Coordinator, the Society for Simulation in Healthcare, founding committee member, several program and committee positions, the German Anesthesia Society, Simulation Program Coordinator, and the American Society for Anesthesiology SimStat Development Liaison. He also is a past president of the Society in Europe for Simulation Applied to the Medicine. We really know SESAM. His professional focus is on improving healthcare globally through high-tech and data-driven solutions. He strongly believes that global healthcare challenges need to be addressed through efficient, goal-oriented training and education initiatives. Stefan is a member of the Multidisciplinary and Multi-Professional Human Performance Excellence Council at KAI. Finally, he's a well-traveled global ambassador for the simulation in healthcare education. Stefan, thank you again for this special opportunity. This is a unique opportunity. We really want to thank you for giving the opportunity to share your lecture. So please, the word is yours.
Thank you very much, Jordi, and for introducing me and for these kind words. I'm very happy to be here. I find this quite exciting. So I want to say thank you for the opportunity to speak here. I have to apologize that I have to speak in English and I cannot do that in Spain. And on top of that, I bring a German accent with me, but I hope we will manage through. Definitely, I will be happy to answer questions or discuss in the end if there's interest. And with that, I suggest I just start with my presentation, which in itself is focusing on healthcare. So I see education and training not as the main focus. It's more a tool, in my view, on how to improve how healthcare is delivered. So making healthcare a better place, a safer place, helping both patients and workers in healthcare to profit from a better system. And I think education and training are a means to achieve that goal. I'm not going to say any more about my personal background because Jordi has done that. I just want to highlight one of the last sentences he said was that I'm part of the Human Performance Excellence Council at CAE, which is a group that definitely does not look at technology, despite my presentation is going to be a lot about technology, but this group looks at non-technical skills. So how healthcare decisions, communications, task allocation, workload distribution, and so on can be achieved to create better teamwork. So that's a second topic that I'm dealing with, not so much today, but of course, if there are any questions to that respect, I'm also happy to react to them. But it's a second element that is very important to me. So the first element of my presentation is really about the problem in healthcare and healthcare education. Why should we even think about this? What are the challenges that we face in healthcare? I personally think the challenges are big and they are old. And basically, it can be described as a shortage of staff. We do not have enough people who work in healthcare. which is a significant problem. It's a big problem, and it's a long-term problem. So this article here is 20 years old, but it already describes that there's a shortage of nurses. And the authors already say that the demand is growing, but the supply of new nurses is actually shrinking. And in this particular publication, they point this out as a very big problem for the developing countries, which definitely is true. But please understand, it's not limited to developing countries. So what has been described 20 years ago as a beginning maybe of a problem, we see today as a full-blown problem. So the International Council of Nurses, which represents more than 100 nursing associations, it represents almost 30 million nurses worldwide, is basically repeating the message and says, well, we do not have enough nurses, but we also know that a lot of nurses are thinking about leaving their profession. And they are not just thinking about that. We see an increased rate of nurses leaving the clinical work. And the estimation, as a result of all of this, the estimation of the International Council of Nurses is that we will, in the next years, we will need 13 million of nurses to fill the gaps. And this is a huge need. And it doesn't even matter if the number is correct. So even if they would be wrong by 3 million, if it's only 10 million, it's still a big number. If it would be only 5 million, it still would be a very big number. So the message here is we are already seeing and we are facing a growing shortage in nursing. And the World Health Organization supports that view. They say there's a global shortage of health workers, and they focus on nurses and midwives, just as I do, but not because I think it's the only professional group to look at, but it's by far the largest professional group. So if we do not have enough nurses, we see a huge gap in healthcare just because we need so many of them. But of course, there also is a shortage of midwives, as it is listed here. There's a shortage of physicians and other healthcare workers. So the World Health Organization estimates that by 2030, which is not too far away, we will need 9 million additional nurses. So whenever you look at this, there's a big gap in the people who can provide healthcare to patients. And that's a very significant message. And it's going to affect one way or the other everybody. We may think it affects us because we are professionals in healthcare, but definitely it affects everybody who is going to be a patient. And eventually, everybody is going to be a patient, including us at one point in time in their life. So this is a very significant challenge to address. And it needs to be addressed in our part of the world, let's say the Western world, the rich world. So as an example here, Europe and the US, who both state the same findings, and they call it a crisis, a serious problem. And I absolutely agree with that specific view. But of course, it has also been described in other parts of the world. So we do know that in Asia, and specifically here, pointed out by the World Health Organization for Southeast Asia, a big number of nurses are needed. So out of the 9 million, they estimate 2 million almost are needed in the Southeast Asia region. And in sub-Saharan Africa, which is viewed as a specific region of the world, a large number of countries describe a critical shortage of healthcare workers and describe a huge deficit as well in a population that already has a very low ratio between healthcare workers and healthcare and patients who need healthcare support. So it's maybe a more obvious problem in an area where the shortage already exists, but it's definitely a global problem. And This, of course, has been worsened, but not created. It has been worsened by the situation of COVID-19. So we started with not enough physicians and nurses and other healthcare professionals. They already, before the pandemic hit, did not have enough time. But we know that healthcare lost workers during COVID-19. And there was a significant concern, and in all the European countries, but also in the US, and of course in other parts of the world as well, where there was a big concern and an experience that we did not have enough healthcare workers to deal with the pandemic. That, of course, has been tragic. It has been tragic that we lost healthcare workers to the disease. Some of them were sick, some of them even died. Um, but what it also created was an additional decision of people to leave the profession after the pandemic. And all of this creates a backlog of patients who could not be treated during the pandemic for the reason of a shortage and a burdened healthcare system. But these patients in the future will need to be treated. So cancer treatments and so on have just been postponed, and we can expect, of course, to have older and sicker patients to come in the future. So there's a sort of mountain of patients potentially coming to us. And I want to illustrate this with a depiction of the healthcare situation here in Germany. What you see on this screen is the number of intensive care beds in Germany, which is monitored daily. The total number and the number that is available and so on, you can see on public websites. So the numbers that we look at start in October 2020 and end in April 2021. And we started at that point in time with about 30,000 intensive care beds. That's the blue curve here. And you can see that there's a decline in the number of available intensive care beds. And when I say available intensive care beds, a decline means not that the beds are disappearing, obviously, but it means that people who work there disappear, and these are mainly nurses. And there's a parallel increase of this gray curve where you can see that the number of patients in intensive care who suffer from COVID is increasing. So theoretically, we could assume or could have assumed until this point in time that while the number of intensive care beds with corona patients increases, the number of healthcare workers decreases, which in itself is already alarming. But what's even more alarming is that in early 2021, the first, or this at that point, a second wave started to go away. So the number of patients with COVID in intensive care declined, but the number of beds did not increase again. So the problem of a loss of intensive care beds is probably permanent. We have lost people who decided not to work in healthcare anymore, or not in the intensive care unit anymore. If you say 3,000 beds of 30,000 are missing, that's maybe just 10%. But in fact, it's more important because it means it's 3,000 beds missing every single day. And even before the pandemic, we needed these beds. They were not free. They were not just waiting for patients. So if you imagine you have a year of 300 or more than 300 days, obviously, and you have 3,000 beds missing every day, you already talk about 1 million of lost treatment days of opportunities to treat patients in intensive care in a single country, in this case, Germany. So this tells us how serious the backlog is. Now, if we accept that this is a problem, then the question is, what can we do about that? If we do not have enough healthcare workers, we cannot just invent them or build them or something like that. What are the steps that we can do to address the problem? We cannot ignore it. Well, in many rich countries, the first idea is let's hire more. And this is probably not going to solve the problem. First of all, if they are not available, we cannot hire them. Even if we pay more, there's a limit to the number of workers we could get. And also, of course, it's getting so expensive that in some places of the world, this becomes not sustainable. And in rich countries, it's easy maybe to reach out to countries, to developing countries, for example, to hire nurses or other healthcare professionals from there. But of course, this only shifts the problem to another part of the world. So it's not really a solution to anything. So this leaves two opportunities on how to address the problem. The first one is filling the pipeline. That means we train and educate more healthcare workers. And the second step is to deliver healthcare more efficiently. So those workers who already are in the system can work more efficiently and treat more patients better, potentially with a fewer complications than before. And I would like to focus on these two methods, filling the pipeline and delivering healthcare more efficiently to address the problem of a global shortage in healthcare workers. And I would like to give you a few examples on how I think this could be addressed. And in principle, the goal here needs to be to increase efficiency both in education and in healthcare delivery. And a big element of that, the answer to that problem is to use technology. I mentioned already that I'm part of the Human Performance Council, and I'm absolutely sure that we need to find better ways to work in teams, to perform better with our colleagues, to make fewer mistakes, and so on. So I'm absolutely a believer in all of this. But I think another element of what we do has to be around technology, and this is what I want to talk about here in this presentation. And I would like to give you a few examples of that. If we look at training and education, today this is a very personal thing. So today there is a student or several students facing a facilitator, a teacher. They sit down and read books, they go to lectures, they practice together, they go to wards to see patients and so on. All of this is very personal. And it's also to a degree very complicated, because it means we have to go somewhere, we have to meet somebody, we need a space, an appointment. And even if we do something very modern like a simulation center, we add to the burden of the education system, because now we need a space, we need equipment, we need operators, facilitators, cameras, time for debriefing, and so on. I personally think the more we can streamline these processes, the higher our efficiency is going to be. So if we are able to give a lot of work to machines instead of only humans, then we are going to be more successful. So if we support feedback by objective performance measurement instead of just subjective messages like, I think you did this very well. If we do not always need to meet a facilitator at the same point in time, if we do not need real rooms and could meet in virtual rooms occasionally, if our work can be supported by artificial intelligence, if we use more software, then I think we can be successful. Specifically, I would like to point out that simulation today frequently is thought about as something that helps undergraduates, medical students. It is absolutely important, in my view, to look at clinicians who are delivering healthcare and who do the work, and where the work is in principle dangerous to patients, because if a mistake happens here, then it can have tragic consequences. So elevating the learning system is the key. And again, who are we looking at? We are looking at nurses a lot, not because it's the only group in healthcare, but because it's a huge professional group. And then there is another group to look at. Of course, we want to look at everybody, but another group of healthcare providers where it's absolutely important to look at. And this is where work is dangerous. So if somebody cuts or does somehow invasive measurements, then it's inherently dangerous. There's a risk to that. That's also, it's not just true for surgery, but for every type of acute care. From a hospital perspective, certainly there's an economic view of this. So surgical procedures in a lot of hospitals are procedures where the hospital makes money, so they want to look at these, for example, and of course places like intensive care play a very big role here. So first example, I would like to give you something called SimStat, which is a self-directed, a high-stakes exam in the form of a game. And the game itself is like an ego shooter. So you are placed in a 3D environment, but instead of seeing monsters and shooting and fighting the monsters, you have a patient, a surgeon, a team, a nurse, and so on. And in this case, the player is in the role of the anesthetist who has to treat the patient, work with the team, give drugs, make a diagnosis, discuss with the surgical team if the procedure should continue, and so on. It's a highly, highly interactive game. We have done this with the American Society of Anesthesiology, and the environment is very realistic. The cases have been defined by the American Society. And why are people playing this game? Because in the US, anesthetists have to recertify every 5 to 10 years. The exam is called the MOCA exam, and today SimStat is the most popular method of participating in the MOCA exam. Because it's you don't need to travel, you don't need to make an appointment, you just play the game when you have time, but you can also fail, of course, and despite the fact that you can fail, it is very popular today. What it means from our perspective is it's a big opportunity to collect data of what is happening. We are not interested in the names of the individuals who play the game. We just want to observe what they do. And we have collected about 500 million data points by observing about 100,000 sessions of the game. And there are a few things that I want to share with you that we have learned from that. So first of all, about 70 or 80% of the 70% of the people who play the game pass within 10 attempts. So they need to play it several times, but after 10 times playing the game, most people have passed 70%. And then if you play it 5 or 10 times more, maybe the pass rate becomes 80%, but then it doesn't really increase anymore. So about 20% do not really profit from playing the game. And these are people we need to identify. These are struggling learners. And of course, this is not limited to this form of education. It means for each method of education, there are people who profit more or less from that. And here we can identify them by looking at the learning curve and seeing who needs extra attention because they're in trouble. There's one element more that I would like to show you. In this picture, you can see a lot of blue dots, and basically on the every blue dot is a behavior, and some of these behaviors happen frequently. This is when they are right on the graph, and some of these behaviors are very desirable, so they're very high on the graph. So ideally, in the pink quadrant number 4, we would like to see a lot of blue dots because that's frequent and very good behavior. And you see the quadrant is empty. And that means the US anesthetists who play this game with this specific clinical problem are not really doing as good as they are supposed to do. And if we want to teach them, it's probably a good idea to take dots from the yellow quadrant because this is very good behavior that is not applied frequently. And to teach specifically these. So we don't need to give them the book of anesthesia, we just teach them the things that happen, the blue dots, basically the topics of the blue dots in the yellow quadrant number 2. So it not only tells us where the deficits are, it also gives us an idea of what to do to improve performance in the future. Out of 500 million data points of 100,000 sessions of observed clinical behaviors. I think that's very exciting. Another tool that we have built is called Maestro Evolve. Imagine a simulation center, as you know it, of course, but you have it in your computer. It's a virtual environment. So there is a simulated patient, and you can interact with the patient as you do in a simulation center. But everything is virtual. Your team is virtual as well, and you have virtual equipment. So there's an intensive care ventilator or an anesthesia machine. There's a patient monitor. There's also a facilitator who can run a script or introduce complications. And everything that you do as a team in this virtual environment, everybody can stay at home if they want, or you can meet somewhere. But everything that you do, even if you stay at home, is recorded. And that includes you and your conversation in a video for later debriefing. And we used the same methodology of the virtual equipment that we had in the Maestro Evolve environment to build simulated medical equipment. So this is an example of an anesthesia machine, which is not an anesthesia machine, but just a device model of an anesthesia machine, which exactly behaves like an anesthesia machine when you connect it to a simulator, to a mannequin, but it does not require gases, for example, not a scavenging system and so on, but you still can use volatile agents, or at least simulated volatile agents, to give anesthesia. I'm not going to go into many details. I just want to show you examples of applications of HoloLens, where it's possible to look inside of the patient and to understand what shoulder dystocia really means when delivery of the baby does not function. The complicated anatomical situation here is easily understood if our students wear a HoloLens and can look inside of the pregnant patient and see where the baby is not moving. That increases efficiency because it allows faster understanding of what's going on. And the last example I would like to give you is self-directed learning, which is a cooperation that we have done with a company that works in home dialysis. These patients, sick patients, of course, with chronic renal failure, typically have been taught by nurses how to do dialysis at home, and that required about half a week to be trained. And we have developed a HoloLens program for these patients where they are put into a virtual environment. And in this virtual environment, wearing the HoloLens, they can interact with the devices they need, and they can practice to manipulate their equipment and so on. So it's very interactive experience. And it also gives feedback to pass or fail. And why is this relevant? It's not just because it's not just because it trains patients, which is unique. Instead of training healthcare professionals here, the patient is the focus, but it also increases the efficiency of the nurse. So this nurse, instead of spending 25 hours educating a patient, now can do other things, which increases, of course, the nurse's efficiency in healthcare delivery. We are not leaving the patient alone with that, but we give an additional channel to learn, in this case, to relieve work from the healthcare professionals. That's the idea here. So with this last example of technology, I would like to attempt a summary here of what I just talked about. And the first element for us to understand is the seriousness of the situation. There's a shortage of healthcare workers, which is so serious that it threatens care on a global scale. This is something that we need to take serious. So we need to address that. And I think it can be addressed by increasing efficiency, first of all, in how we educate, so we get more healthcare workers faster. And then, of course, we need to find out how to improve the delivery of healthcare itself in the clinical environment, so people can treat patients better, and patients have and workers have a better experience. And the efficiency, which is the key element here, to improve education and training and clinical delivery, can be achieved not just, but definitely by the application of high technology. And with that, I would like to say thank you. That's my presentation. I hope it was not too long and not too focused only on technology, but I'm happy to enter a conversation, discussion, answer questions. Thank you.
Yeah, Stefan, thank you very much for your presentation. I'm really impressed. There is a problem. You have the vision about what's coming, uh, about the shortage of healthcare professionals. So let's find solutions. And here you presented, yeah, fascinating solutions for efficiency in terms of training. Uh, Please, the audience, if there is any question, don't hesitate to write on the chat. And as Stefan said, he's going to be really very happy to answer you. I just have a couple of questions regarding these amazing tools like SimStat or Maestro Evolve, as I understood, it's like you are imitating like real simulations, because you can train teams, not only individual. So there are people around that there is a team inside, and at the same time there is a facilitator on the back. On the back, I mean, the possibilities are, yeah, wow, like infinite, infinite in terms of like of course there is objectives in the scenarios, in the real, in the on-site one, in the real ones, but some of the times we're changing like the blood pressure depending of what the participant is doing. So here there are also the same possibilities. I mean, it's not like an algorithm, because there is always a facilitator that it's controlling each, I would say, step that the participant is doing. Is it like this?
It's it's different in both examples. So Maestro Evolve, in fact, does require a facilitator. So this is very traditional and very close to how a simulation center operates. So there's a group of students, if you will, but this time they are not in the simulation center, but rather work from home or from an office or wherever they have access to the internet. Um, and they have a problem that they need to solve as a team. They are observed and guided by a facilitator, and of course, videos are taken for the video debriefing, a data recording, I should say, not just video. And this is like it would work in a simulation center. So the facilitator can make changes to the physiology, change the blood pressure, and all the examples that you gave. So this is a very almost, if I can say that, traditional simulation. It's just different because nobody needs to travel to a simulation center and meet in person. And I would like to point out that we are not doing this because of COVID. We have started this project even before because of the increased efficiency. You know, some people just cannot really travel because they need to deliver anesthesia on the next day again, so they cannot move. So in this case, the facilitator or operator, whatever you want to call this person, is required. In SimStat, in fact, there is no facilitator, which is a remarkable situation because it gives a lot of responsibility to the quality of the game. And I can tell you, when we started this a few years ago, this was our biggest concern. So, well, we had two concerns. One is the technology going to work? If a lot of people play the game, that quickly went away. But the second challenge to us was, what are people going to say about the quality of the scenarios and so on? And I'm very proud to say that we of course it's not zero, but for sake of ease, I would say there are no complaints here. Um, and this there are several things to say about this. First of all, it makes us very proud. And it makes us especially proud because people fail, right? It's not everybody passes, and certainly not immediately. Only about 4% pass immediately, and still they don't complain. It would be very easy to say, well, this is just a bad program, and and I'm a perfect anesthetist, but I failed because of the bad program. This is not happening at all, and we believe, of course, it's part of the content quality, but we definitely believe, which comes from the ASA, by the way, just to state this clearly, but it's also because of the model of physiology that's used here. So this patient behaves very similar in a recognizable way to a real patient. So as an anesthetist, I recognize the reaction. So I give a drug and I'm not surprised. I look at this and say, oh yeah, this is what I would expect to happen. And this, of course, adds a lot to the credibility. And the same is true for the device models. So the anesthesia machine behaves like an anesthesia machine and so on. And because we cannot predict what the people are going to do in the game, that was a bit risky, but it worked. And how is the game now measuring performance? It does this in two ways. First of all, it observes the action. So what are people actually doing to the patient, or which decisions do they take? How do they communicate, and so on? And this is something that we observe, the game observes, and it says, well, within the 10 minutes, we expect them to give a certain drug, for example, or we expect a conversation with the surgeon, for example, or we expect a call for help. And these things happen or they don't, or they happen partially. And for each version of activity, we give a certain score. So that's something that we call the action score. And in the end, a player gets an action score and also an explanation where lots of points were lost and where performance was really good. And there's a second score, which we call the physiology score, where we basically define a corridor of safe parameters. So a safe blood pressure, a safe heart rate, and safe saturation values, and so on. And if the patient is inside the corridor, it's good. But if one of these parameters falls out, drops out of the corridor, then points are deducted. So the physiology score is not looking at whether you um, um, were following all the guidelines, but it is more looking at how the patient is doing, which of course is relevant. And apparently the two scores are good enough for the participants to be satisfied, and it offers, by the way, an opportunity for very detailed feedback. So, for example, it's not happening yet, but it could happen that the ASA learning management system looks at the score and says, well, you were very good in ventilation, but you were not so good in maintaining the blood pressure. So the LMS could automatically deliver, let's say, an article about blood pressure management for these people. So it allows a sort of closed loop education. Sorry for the long answer.
Oh wow, that's really amazing. So yeah, thank you your for your for your comments. There is a question from the audience from Guillermo Pardo, and he's asking like, can we reproduce standard scenarios similar that we have on a KAI simulator like Ares with Maestro Evolve?
Yes, exactly the same. So in fact, the software, the Maestro software that operates the simulators is the same software that is driving Maestro Evolve. We sort of took it out of the mannequin and put it in the cloud. So the same software runs Maestro Evolve in a cloud version. And a last remark to this, it follows our philosophy. We think some people can come to a simulation center, some people can't. Some people have a ventilator, some people don't. And whatever the equipment and what the personal situation is, and maybe what the level of resources available is, we want to give everybody a similar experience, or at least as similar as possible. We realize there's a continuum of resources that is available. Some places have a lot and some places do not have a lot, but to the participants, as much as possible, we want to allow a similar experience independent of the resources.
Yeah, thank you. If anyone has any more questions, you can write it on the chat. On the Twitter, and I can read it. So you can leave it on the Twitter as well. So I just wanted to ask you regarding your amazing experience. Yeah, I would say like in simulation when we are writing the objectives in terms of the design for the designing the scenario and everything. Most of the time, at least in my experience, we classify in the objective in non-technical skills and technical skills. I just wanted to know your thoughts about the tools that you presented. If there is a balance between technical and non-technical skills, or if it's better for non-technical, also for technical. What do you think about that?
Yeah, that's a challenge to answer that question. So first of all, I think if people want to practice something in healthcare, they need knowledge first. And it's not easy to say this in front of colleagues, obviously, but it certainly also affects me. So I feel safe to say that in some cases, knowledge is needed more than we have it. So I totally believe in a need of traditional, or not traditional, but to learn knowledge at one point in time. It doesn't have to be traditional. It's not just reading books. It could also be conversations, lectures, e-learning, and so on. That's important. Simulation is not a perfect tool to transport knowledge. It's not efficient. Of course, it works, but it's maybe not efficient. So this is not what we aimed at, and I think you probably would agree when I say a simulator is not the perfect teaching tool to just transfer knowledge. The second element that people talk about are skills. So dexterity, how to insert something, and so on. Then to a degree, of course, a simulator can be a tool for that. For example, for airway management, and you feel the pressure, not just to make the decision only, but also to really insert the tube and so on. The decision-making pressure, of course, is here as well available, and I get to that. But of course, the dexterity element is missing when it comes to online and distance education. So skills, when it comes to technical skills, you cannot really teach them using a serious game. Non-technical skills, I think, are something that I really, where this is a good platform, because part of the non-technical skills is, well, I just make a list of a few examples, right? So first of all, there's situation awareness. You need to understand what's going on. You need to make sure your team knows what's going on, right? So you share information, you request information. You all want to have the same view of the situation. You all want to understand that this is an airway management problem. This needs to be explained in a virtual environment as well as it would be in a simulation center and in a real clinical situation. Task allocation. So I don't know, you change please the setting of the ventilator, and you give a drug, for example, is very similar in a virtual environment. The communication element, the reading back, the listening, making decisions in the first place. These are all part of that. So I think it's a tool that is astonishingly good for non-technical skills. I really am quite impressed. And even the SimStat, the game that does not have a facilitator and does not have a proper debriefing section, is very good at that. But Maestro Evolve, because it's embedded in a video environment, so you have a regular feedback where you can replay and watch and listen to the conversations again. That's astonishingly good when it comes to non-technical skills. There's one thing I have not mentioned here, which has to do with technology again. We have a version of these virtual environments in virtual reality. So you can wear an Oculus glass, and you feel you stand in the same operating theater, and or ambulance or whatever it is, and you have to interact virtually with the equipment. From my experience, I can tell you this is extremely impressive. It's not just the environment, but it's also the presence that you feel from the others, from your team, because now you see an avatar, and this avatar is close to you. So you can look at that other person, and you can have a conversation with the other person. And even, of course, it's the technology of the Oculus, but even you hear them, they are close to you, right? They speak right into your ear, or not if they are further away. So these human elements that are so important when we need to discuss with the surgeon, for example, right? That can be challenging for an anesthetist. I mean, maybe it can be challenging for a surgeon as well, or to build a team with somebody else, and you feel the physical presence. That is extremely well. How should I say? Extremely well, astonishingly well using virtual reality. I was very impressed when we did that. We have not rolled that out, but from exercising this, I can tell you that's going to be extremely exciting.
Yeah, well, thank you. And I just wanted also to ask you that I can see a lot of advantages in terms of, yeah, I would say you can reach a lot of participants, or the participants can save money, they can save time, yeah, because they can stay at home, or maybe they are at work and they have half an hour and they can train, or an hour. So I think that's really amazing, this vision for, and now it's real, no, for training for this problem that we are, that it's here, no, this shortage of healthcare, or shortage or not shortage, I mean, for training. But in terms of usability, from your experience, the first time that students get in contact with the platform, is how do you think that they are feeling about that? Because yeah, I know that yeah, the times are changing, so there are really no technologies, and sometimes I'm just thinking myself, stop, because some people see the things different like me, because I was not used to play with a computer. So, but I know that nowadays everything has changed, no, and everybody has a mobile phone and everything. So is this really a barrier for the students for the first time or not? What do you think about that?
Yeah, great question. Thank you. And I can tell you that has been a real concern. I'm not sure if you see it very well, but I have a lot of gray hair. And despite the fact that I'm working in a technology company, and not just me, a lot of my colleagues, right, were very seriously thinking about, is this going to, is this going to be attractive, right, to somebody who is who is not exactly looking to play computer games, right? Some people grow up with that, some people don't, and would they feel comfortable with that? So we did, and in the terms of the SimStat game, it's MOCA, it's an exam for specialists in anesthesia. So they already had an exam 5 years ago, or 10 years ago, or 15 years ago, or 20 years ago. So these are people who are experienced in anesthesia, but maybe not experienced in playing games on a computer. And there must be a threshold, right? Some of them we expected to say, this is stupid, I'm not going to do this. So part of what we expected was a number of people who would say, I'm not accepting this. And we did not know how big this number was. Um, and the second problem we expected was people calling us and saying, this does not work. My computer, whatever it doesn't work. Um, and the first thing is, um, do they like it? Apparently they do, because today, as I said, it's the most popular way of doing the MOCA exam. So some people still do more traditional ways, so some go to simulation centers and some do other things, but this is by far the most popular version. And imagine if you are an anesthetist with 10, 15, 20, I don't know how many years of experience, then you are 40, 50, maybe 60 years old, and people play the game. So that was a very nice surprise to us. When it comes to the technology problems, the game doesn't work. First of all, we built the game in not the highest possible graphical quality. We wanted to make sure that it plays on every laptop with every internet connection. We did not want people to need a very specific version of that. So we wanted to make sure it also works in rural areas, for example. So the graphic is nice, but it could be much nicer. We said, no, let's not do this because of the internet bandwidth restrictions. And, and the second thing that we did is we operated a hotline. And it was a 24-hour hotline because we know most of the people play the game around midnight. So when you're on call and so on. So we said, okay, if that's the case, we need a hotline that is available for people who have problems. And I can tell you that hotline does not exist anymore because we did not get calls. And the few calls that we got were medical calls. So somebody said, well, which drug should I should I give? And of course, our technicians would know the answer, but of course, it would beat the purpose to, to give the answer. So the hotline doesn't, I think it does not exist anymore because it turned out, yeah, we don't get any calls. So the technology seems to be good enough.
Well, nice experience. Yeah, yeah. I think yeah that we really learned a lot today. So Stefan, thank you again very much for giving us this unique opportunity to discover this really new. I mean, not new for you, but for I think for most of the audience, these technologies that they work. They work, and they are here for helping us for these kind of gaps or problems that we have to face. So just wanted to thank you once again, and yeah, see you next time. Thank you so much.
Yeah, thank you very much, Jordi. Thanks for moderating this. thanks for all these exciting questions, and thanks for the opportunity to give this presentation in the first place. It has been a pleasure. Thanks a lot.
See you.